Hi, good morning. My name is Otis Toussaint, and I'm coming to you live from the AUSA virtual conference. This year, we are doing it virtually. We're all 100% virtual because of the new reality that we're in. We're in a COVID-19 reality. But today, I'd like to talk about medical readiness. Medical readiness, one of the paramount things in Army medicine. And I've got a panel today of 3 decorated officers that will be giving you all the information today regarding medical readiness. And I'd like to introduce my entire panel right now. Hi, team. How are you all doing? Good morning to everybody.
Good morning to you. Hi.
Good morning. Good morning. Good morning. I'd like to have everyone go ahead and just introduce themselves to the actual viewers that we have. We have, it looks like almost 20 viewers right now on our live discussion. So go ahead, we can start from the top with Colonel Stevens.
Good morning and well wishes to all. I'm Lieutenant Colonel Yolanda Stevens, currently serving at OTSG G37 Medical Readiness as the Chief of Policy and Training. That's about it.
All right, thank you, ma'am. Good morning to you. Next, we will have Colonel Andreas.
Hey, good morning, Lieutenant Colonel GARDNER Andreas. I'm also part of G37 Medical Readiness. I'm the Operations Branch Chief.
Okay, thank you very much, Colonel Andreas. And last but not least, Colonel DINTAMAN.
Hey, good morning. I'm Colonel Jay DINTAMAN, the Chief of G37 Medical Readiness and the Office of the Surgeon General. I'm a medical corps officer. I'm a neonatologist, which is a physician for premature babies, and just started in the position a couple months ago. But I'm thrilled to be here and also super excited to be backed up by such strong team members in Lieutenant Colonel Stevens and Lieutenant Colonel Andreas as well. So pleased to be here this morning.
Awesome, awesome. Good morning. And so I really appreciate you all joining us on this panel this morning. The Surgeon General of the Army, General Dingle, also appreciates everyone taking the time this morning to come and actually talk about medical readiness for our viewers today. But before we go into the slides, I'd like to have, when the terminology medical readiness is presented to you, I'd like to have the panel go around, just tell us in a quick, brief manner, a 15, 30-second definition, what exactly medical readiness means to you. Ma'am, if you could go first.
What medical readiness means to me is being ready to serve wherever is needed medically.
Okay, thank you. And Colonel DINTAMAN, what about you?
So I'd echo those sentiments. Individual medical readiness is fundamentally a responsibility of the individual soldier, and it basically means that that you, as the individual soldier, maintain your medical readiness so that at a moment's notice, if called upon, you can be deployable to austere environments to fight or function in whatever your MOS is. And so it fundamentally is kind of one of those basic soldiering tasks that needs to be maintained on a regular basis. Because if an individual is not medically ready, then there is a decent chance that they may not be actually able to deploy. And the commanders, our country, is counting on every service member being ready to deploy at a moment's notice. And while readiness doesn't equal deployability, there is a definite connection there where our individuals or soldiers who are not medically ready, many times or many cases may not be deployable as well.
Okay, so medical readiness essentially affects the fighting force strength overall for all of our military organizations. And Colonel Andreas, if you can give me just an additional, an addition to your predecessors, what they've said.
Yeah, so the most important thing that Colonel DINTAMAN said there was austere environment. So when we deploy our soldiers, we only deploy them to austere environments. We don't typically deploy them to Disneyland or somewhere nice. So individual medical readiness means that the soldier needs to be fit and able to go into an austere environment where they may not have a great amount of medical capability to provide them ongoing care. So they got to be strong and fit and ready to be in that environment for an enduring period of time, and be able to do their mission with strength and endurance. So that's one of the key things of medical readiness is looking at soldiers continually to make sure that they're constantly staying fit. So like Colonel DINTAMAN said, at a moment's notice, they can go and be there for a period of time without needing access to medical care.
Okay, thank you very much.
I'm going to jump right back in here because there's another issue I wanted to just address. You know, we know historically that the biggest the biggest medical detractor of effectiveness for our service members when they get into theater is disease non-battle injury. And we also know that it is much better medical practice to prevent those issues versus actually treating them after they've actually occurred. And so individual medical readiness is really preventative medicine for our soldiers to try to reduce those disease non-battle injuries for when they get into that severe austere environment. We know that there are going to be casualties at war, and we know to a certain extent because we're in a because we're in an austere environment, there's going to be increased risk for those disease non-battle injuries. But having soldiers be fully medically ready is one of the best things that soldiers, leaders, commanders can do to prepare those soldiers to operate in an austere environment and to try to reduce or mitigate the risk of those disease non-battle injuries.
Excellent, excellent. Thank you very much, everyone, for their definitions and rationale for why we need to be a medically ready fighting force. I do know we have some slides and we have some questions as well. And I do know that Colonel DINTAMAN, you're going to be the one kind of guiding the discussion today. So let me know when you're ready and we could go ahead and share those slides with you.
Sure. Why don't we go ahead and get started? I think what we were going to start out with was to talk a little bit about kind of what are the current medical readiness goals for the Army as it currently stands. And we can talk a little bit about kind of where we see that heading. But Lieutenant Colonel Stevens and I were both going to handle that. If you could bring up the medical readiness goals slide, I think that would be a good place to kind of start our discussion.
Okay. Is it this one?
It should be the next one, I believe.
There we go.
Oh, one more. Sorry.
One more. It's all right.
There we go.
Mm-hmm.
Okay. So Lieutenant Colonel Stevens, you want to go ahead and start the discussion?
Sure. Again, currently the individual medical readiness goal is 85%, which is the MRC 1 and 2 for reporting purposes in accordance with the IMR DOTI 6025.19. In accordance with AR 40-502, the medical readiness goal is 90%, which is in line with the pending revision of the IMR DOTI. And the DoD goals is less than 5% for non-deployable soldiers.
Right. And so the important things I think to take away from here are that the Army has steadily been increasing their medical readiness goals over the past couple of years. And so 90% medically ready, as Lieutenant Colonel Stevens mentioned, a combination of our MRC 1 fully medically ready and then MRC 2 partially medically ready. That goal has progressively increased as she mentioned, currently 85%, but we anticipate that will be moving from a DoD perspective up to 90% here very shortly. So the Army has already had that goal, although the DoD is going to be matching it here very shortly. When we talk about those medical readiness categories, medically ready MRC 1, fully medically ready is fairly self-explanatory. Essentially means that when you pull up your IMR, that all of you're entirely green. You've had all your annual checkups. You have all your immunizations. You have DNA on file. When we move into partially medically ready, those are where you may have a couple of those items that just need to be corrected. Maybe you need to still have a lab drawn, or you're missing an immunization or something like that. but it is not judged to be impacting your ability to deploy as well. And the idea being that that individual, if they're MRC2, if they have one of those small items that needs to be corrected, that by the time they get to SRP to deploy, those things can be corrected kind of on their way out. They're relatively minor. Now, so the MRC1 and MRC2 goal, as I mentioned, currently 85% according to the current DODI. Army's, however, is 90%. And then Lieutenant Colonel Stevens mentioned that non-deployable number being less than 5%. It's important to recognize that that's the total non-deployable number. So that's not medically non-deployable. That is the total non-deployable. And so non-deployable is a combination of both administratively being non-deployable as well as medically non-deployable. And so of those, different percentages, the largest percentages is medically non-deployable when you compare it to administrative non-deployability. And so for the Army, and we can talk a little bit here in the next couple slides in terms of kind of where the Army currently stands. There's about 60 of the non-deployable soldiers, about 60 to 65% of those are medically non-deployable versus being non-deployable for some other reason. And then, as we kind of mentioned, while medical readiness doesn't equal non-deployability or deployability, they are somewhat aligned, and they're going to be progressively moving to be more aligned in the future. And again, we don't want to equate medically ready to deployability, because there are other factors that come into play there. But as much as possible, we want commanders to be able to look at what the medical readiness of their force is and be able to make good estimations about the deployability of those service members.
Okay, so I guess this can kind of connect to the first question that essentially we have regarding medical readiness. And that first question for the panel is, so what are the medical readiness goals for the Army? I think you've kind of briefed on that information, sir, but is there a certain hard number that overall that we're trying to hit?
Yeah, I think I would say that medical readiness goal, as we mentioned, is 90% at this point, which is a combination of the MRC1 and MRC2. And then again, it's not a medical readiness goal, but deployability. We want to have that non-deployability. We want to have that less than 5%. As I mentioned, that's a combination of both admin as well as medically non-deployable. Now, we do not, within G37 medical readiness, we don't have oversight on deployability. But as I mentioned, a lot of what we do impacts medical readiness and the policy behind medical readiness, and that, in many cases, drives deployability determinations. And so it's an indirect effect versus a direct effect from medical readiness.
Okay, so let's go back to the slides. And that was a good first question. So would you like to move on, sir?
Sure. Why don't we move on?
Okay, what's the next thing that you'd like to go to? This one?
Well, I think what we'd like to do is go back to kind of where we currently stand. And so let's go to this slide here, total force medical readiness.
Okay.
And I think we had talked a little bit about, or one of the things that we were going to discuss was, the impact of kind of operating in the COVID environment and what's that done to the Army's medical readiness. This is a what we call the total force medical readiness slide, and in the upper right portion of the slide, you'll see deployability information, which we get from G1, and that kind of illustrates what I was discussing in terms of kind of how the medical non-deployability is kind of the larger percentage of the total non-deployability number. But what we focus on is really the bottom portion there, and you can see the level of detail and the breakdown in terms of what we look at and what Army senior leaders and Department of Defense senior leaders see as it relates to medical readiness. And this is data that can be pulled on a daily basis. In this case, what we're seeing is kind of a monthly roll-up, So it's somewhat of a snapshot in time. Also on this slide, it reflects kind of where the current goals are and where the Army currently stands. And so what's, kind of notable about this slide, which reflects data from September, this kind of early September timeframe, is that you'll see, as we mentioned, the Army's medically readiness goals, according to the DoD, would be greater than 85%. According to the Army's internal regulations, it should be greater than 90%. Well, we currently stand around 83 and change, a little bit closer to 84%, but somewhere around 83 and change, and that has fluctuated a little bit. But that's a reflection of operating in the COVID environment. And when you dive in a little bit deeper to try to determine, what is driving that impact, what you find is that it's primarily an increase in our MRC4 category, which are those individuals who are essentially missing an annual dental exam or have an expired periodic health assessment. Now, those are requirements that previously had required in-person encounters. So the soldier actually had to go to the dental clinic, and frankly, for dental, the soldier still has to go to the dental clinic, and they have to have an encounter with the dentist to actually do an exam and bring them or kind of meet that annual requirement. And that's something that still is required. But with regards to the periodic health assessment, COVID has been a bit of a double-edged sword in the sense that, yes, it has certainly impacted readiness services throughout the military, but it also has kind of driven innovation in ways that we maybe wouldn't have envisioned kind of pre-pandemic. And we've kind of discovered that, there are opportunities for utilizing alternative methods to completing some of these requirements. And we'll talk about it a little bit more in the future, but one of those would be something like virtual encounters. So using virtual PHAs to try to meet that requirement. And so our medical providers, the regional health commands, as well as the individual MTFs have really been great about being innovative in their approach to try to tackling some of these issues, to try to meet that need and then kind of tackle some of the backlog. And so the reason that we see that the Army's medical readiness and kind of the COVID environment has dropped a bit is really driven by that MRC4 category, which has essentially doubled from where it had been pre-pandemic in terms of the percentage. Now, as we learn to operate in a COVID environment, as the MTFs are able to kind of mitigate some of the impact of COVID, and we become more vigilant about kind of our strategies to protect our service members and protect our MTFs. Our dental colleagues and our readiness providers have really kind of stepped up to the plate, and so our dental providers are actually conducting more dental exams now on the order of several hundred per day, more than they had been doing pre-pandemic to try to tackle that backlog. Likewise, regarding the PHs, the PHA workload has also significantly increased as well. Again, more than had it actually been pre-pandemic, and we're going to need that to continue in order to kind of tackle this backlog. But in terms of kind of where we currently stand, it does seem like we've maybe hit a plateau in terms of the rates of our MRC4, and we are cautiously optimistic we're going to start seeing those start to come back down here shortly. The other thing I would just point out in terms of the other category we haven't spent much time talking about is our MRC3 category, and MRC3 is really that category where we say those individuals are not medically ready, and so that category can reflect individuals who have a permanent profile that is putting them it's requiring them to be referred to a medical board. The soldiers that are pregnant are going to fall into that category. Soldiers that have an extended temporary profile can fall into that category as well. And there are certain service members within there that can be deemed deployable, but still, that's essentially considered to be a not medically ready category. And interestingly, what we have seen is that during the pandemic, that MRC3 category actually decreased a bit. And our thought on that is that there are a couple things that were going on during the pandemic. Number one, a lot of the elective kind of procedures and things that might actually drive an extended profile, perhaps kind of a post-operative recovery profile, that sort of thing. A lot of those elective procedures were put on hold or were delayed. And so we saw a decrease in the number of service members who had actually extended profiles. And so the lack of, or the decrease in the elective procedures is one potential component of that. The other thing was that a lot of the kind of the collective training, a lot of the heavy physical training also was kind of put on hold for a period of time. Again, until we could kind of control the environment a bit better than what had it been earlier in the spring. And so as a result of that, we actually saw our MRC3 category drop a bit. Now it is starting to kind of slightly come back up again, and we think again that's a reflection of the fact that we have more kind of collective training, more physical training that's occurring, as well as the fact that contained within that category is our DRC, or dental readiness category 3, and those individuals actually require some dental work. And the concern in that category is that you have service members who may require a procedure that generates aerosols. And because of that aerosol generation and because of the COVID environment, that requires some strategies, sometimes facility modifications, sometimes it's PPE that's required, but it is a more extensive process to tackle those dental readiness 3 service members than the other categories. And so those are starting to creep up as well. And so we might see those starting to play a more substantial role as time goes by. Mr. Tissan, if you could go to the next slide. The next slide really just kind of gives a visual representation of what I was just mentioning. This slide just really reflects the MRC Go category. As I mentioned, that's the MRC 1 and 2 combined. It's broken out by the component. So we have both the total force, and then we have the 3 components reflected there. And so you can see kind of when the pandemic really kind of hit the United States in kind of the spring spring earlier this year. There was a period of time where we were able to kind of sustain our medical readiness, really because we had been doing a pretty decent job pre-pandemic. And then when those readiness services kind of became more difficult to access, those medical readiness MRC Go numbers have been dropping down. And you do note that there is that distinction between the different components with our reserve components, in particular the USAR, the reserve service members, having more of a precipitous drop than the Guard and the active force. And so that is something that requires our attention to try to help those folks kind of climb back to where they need to be. So I've been speaking a lot right now, and I'm gonna stop talking right now, and I want to open it up to Lieutenant Colonel Stevens, Lieutenant Colonel Andreas. Did I miss anything? Is there anything you guys want to highlight as it relates to medical readiness of the force in the COVID environment?
No, sir. You were spot on.
Okay.
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 I do have a question that
so
Go ahead, sir.
piggyback. Yeah, Mr. Tucson, if you'll post that what is the Army doing to mitigate or reverse the effects of COVID on MR? That's one that we wanted to answer for the audience. And I'll say that, first and foremost, obviously across the Army, we're attempting, because anytime a soldier contracts the COVID-19 virus, then their medical readiness it drops for that period of time until they recover, and then they could potentially have future impacts due to the virus. So trying to reduce the spread by following CDC guidance. And then using the restriction of movement protocols prior to moving soldiers. So, for instance, PCSing them to a new duty station or sending them to schools. And then also TRADOC has focused at the initial entry training locations to do a restriction of movement, basically a quarantine period at the beginning, to make sure that all the soldiers that are going to go into that training cycle or the trainees in that training cycle are healthy and ready to go. And then also attempting to go virtual wherever possible to reduce face-to-face contact or interactions between folks. A good example of that is for us in MR is doing virtual PHAs and doctor's appointments, which has proven to be. Clinics have significant protocols in place to protect those needing access to their facilities for their IMR services. Individual PHA, my periodical health assessment this year, virtually over the phone with my provider after I did my online questionnaire, and that went well. And then for some of my PHA things, I had to go to an MTF, military treatment facility at Fort Belvoir. I did that yesterday for immunizations. I felt safe with the environment. Also yesterday, I went to the dental clinic and got my annual exam and cleaning. So there's protocols in place at our healthcare facilities that allow us to have access, but when access face-to-face access isn't required, then we're doing that virtually. So I'll let Colonel DINTAMAN, if he wants to speak about Viper Clinic, or I can do that.
No, I'm happy to talk about it. So when we talk about, what kind of things have we done to try to mitigate the impact of COVID.
Okay. Well, I'll mention Viper Clinic. So Viper Clinic was stood up down at Joint Base San Antonio. Basically, that's a location where they have providers who are able to execute virtual PHAs for soldiers that don't have ready access to IMR services. Either they're remote or they're MTF due to the COVID environment in their area and things like that. Yeah, go ahead, sir.
Oh boy, I think we may have a big lag here, so I apologize.
All right, Mr. Toussaint, is he maybe having some issues? If so, we can.
No issues here. No issues here. We may have a little bit of a lag. We may have a little bit of a lag in the audio, but
to the next question,
we're good to go.
If there's
okay, let's jump into the next. Let's jump into the next question, team. So the next question is, what is the Army doing to mitigate or reverse the effects of COVID-19 on medical readiness?
Okay, so I think, as we mentioned, one of the things that we've been talking about here or trying to address is the
technology at its finest, right?
Yeah.
Yes.
It is virtual access to medical care where appropriate, and so one of those is the Viper Clinic. The Viper Clinic is a virtual kind of readiness clinic that is run out of San Antonio,
Okay.
but has
So
the
Colonel
ability
Denton,
to actually
do you want
provide.
to move on? Yeah.
Oh boy. Has the ability to provide medical services, medical readiness services to locations that are remote from BAMC, and it can be used to supplement MTF services. It can be used to provide support to a certain extent to a reserve and guard component service members, and that can actually include services for places that are overseas as well. In addition to providing things like a PHA, to a certain extent, they can provide profile reviews. They can, in some cases, actually, as they bring on more credentialed providers, they'll be able to actually provide second signatures for profiles that require a second signature, and or modify a profile that perhaps maybe needs to be modified to account, for example, the implementation of the ACFT. So it's a wonderful resource that is getting more and more attention, rightfully so, and more resources. And so we want to tout that as a service to explore if you're struggling to kind of meet some of the demands of within your readiness clinic. It is something that does require coordination with the Viper Clinic, and they do require a support agreement to be in place. So it's not something that can be turned on immediately, but it is a great resource to explore to see whether or not they can actually provide you some support to try to boost up your services there at your local MTF, or if you're a commander, whether or not that might be a resource that you can take advantage of as it relates to tackling some of those medical readiness issues. Another thing that I want to mention that is a kind of a late breaking, and I think is going to be kind of will be a positive, will have a positive impact for medical readiness, especially kind of in this COVID environment, is related to our medical readiness IT systems. And so for a couple of years now, for a variety of reasons, the only way that service members have been able to access the MedPro system or the MOD system, which is what is required for them to actually go in and, for example, do part one of the PHA, has been to get access from a military computer, or at least a computer on a military network. And that has actually coming up on about 3 years in terms of how long that limitation has been into effect. And obviously, in a COVID environment, if you're isolating at home, or if you're trying to limit service members kind of coming together collectively in one location, having the ability to actually access that system from home or remotely can be really value added. And so one of the things that we think we're in the process of testing it right now, but we're cautiously optimistic, is that we think we have established basically a virtual portal that can be accessed from a computer that's on a civilian network with a CAC reader, that the service member can then go into that virtual portal and then access mods through that virtual portal. So it is not direct access to mods from a personal computer. It requires the individual to go ahead and gain access to the virtual portal. But once they gain that access, it gives them the ability to go into mods then and complete, for example, their part one of their PHA, or any other functions that an individual would need to complete, or and allow them to kind of monitor their medical readiness from home or from a non-military network computer. And so that is something that we know the service has been clamoring for, and rightfully so. and it will not. This is really viewed as, from our perspective, as kind of a bridge strategy, something that will kind of again, hopefully improve access, especially for our Compo 2 and 3 soldiers who maybe really don't have very limited access to a military network computer. But it won't stop us from pushing forward to try to reestablish that direct access, to try to not have to go into that virtual environment. But we think getting that access established early, even if it has to require this kind of additional step to go into that virtual environment, is still a value added thing, and so it's being tested right now. But we don't have any indications that is not going to work at this point. So I'm going to knock on some wood, and hopefully that will be coming out to the services or to the different components in the Army here shortly in the next couple weeks.
Thank you. So what slide would you guys like to move on to next?
Let's see here.
Okay.
Why don't we go to, we'll talk about kind of upcoming policy changes. Mr. Toussaint, there is a multicolored slide with the current MRC system, that one right there.
There we go.
Yeah. Lieutenant Colonel Stevens, you want to talk about this?
Yes. In regards to the policies coming into effect, the revisions of DOTI 1332.45, which is the retention of non-deployable service members, as well as DOTI, as we mentioned earlier, DOTI 6025.19, which is the individual medical readiness DOTI, and DOTI 6490.07, which is the duty limiting medical conditions DOTI, as well as the 29 April 2020 SecDef memo on military service pre-deployment, and we will begin revising AR 40-501, AR 40-502, as well as our DAPAM 40-502 to align with these Army regulations and medical readiness systems of record. Again, with the DoD goals of less than 5% and our improved reporting systems. We will also be working, as you know, with the new implementation of the ACFT as 1 October 2020, OTSG will be working on a new DA Form 3349, which is for the physical profile that allows providers to annotate functional activities and limitations. So we must ensure that the permanent profiles are updated in eProfile. As well, as far as other policies, we are working with trying to implement the new sickle cell trait screening. I'll let Colonel Andreas brief on that a little later, but the Army is planning to implement this universal screening for sickle cell trait screening. As well as we're also, as far as policy goes and training, we're working in developing a JKO online course, writing quality profiles. It's a training course with Medical Center of Excellence, which is MEDCO. The anticipated course launch date is going to be late fourth quarter, but that's coming along well. And then, as Colonel DINTAMAN mentioned, we are working with our mod system, IT change request and prioritization of our systems to come in line with the DOTIs. Previously, we did have a MRC system review, and there was back in September of 2019, we had a OPT, and we were looking to, with the revisions of these DOTIs, moving from 4 categories for our medical readiness categories down to 3. So currently, we have the 4, which is MRC 1, which is medically ready, MRC 2, which is now currently partially medically ready, and then MRC 3 being medically but not ready. So those are your non-deployable soldiers, and then MRC 4 was our medically indeterminate. So currently we are proposing to go to 3 categories upon the publishing of the DOTI, IMR DOTI, going from deployable to deployable with IMR deficits and non-deployable. We have a lag there. Okay, so with those 3 categories, deployable will be a soldier has no medical deficiencies. The deployable with IMR deficits, those will include your PHAs, your immunizations, your HIV, your dental, and your equipment. And the deployable with limitations will be your temp profiles, as well as some of your permanent profiles. And then your non-deployable population will be your temp profiles greater than 90 days with complex conditions to include pregnancy, and then your board, your MAR2s, and your MEBs and your PBs. So currently that's what we have in coming down the pipe with policy changes.
All right, sir. Go ahead, sir.
Yeah, no, that's great. This slide that you see in front of you, I think there's a decent amount going on, but the important thing to kind of recognize here is that you know, the top system really gets kind of complicated, and so if you're, you know, a commander, you know, and you have a service member who is MRC3, well, you have the ability to kind of make a determination, and some of those service members might be deployable, some of them may not be. Your MRC4, you don't really know, you know, what to do about them. They you know, have requirements that are needed to have the individual be ready to deploy. So the thought really with the proposed system that aligns with the IMR DOTI is really let's try to align medical readiness with deployability. Again, we don't want it to equate with deployability, but we want it to align so that when that commander or that service member looks up their medical readiness, they can make a pretty quick judgment based on where they stand about whether that service member is potentially useful for an upcoming deployment or training or whatever that case may be. And it makes it pretty explicit in terms of what service member, what population is non-deployable. And those are really those individuals who have a condition or something going on with them that is going to require prolonged either recovery or prolonged processing in order for that condition to either be resolved or dispositioned, whatever the case may be. And really it reflects that just about every other medical condition, you know, there is the possibility that individual can be deployed if the right things are taken care of, whether it's, you know, getting the labs taken care of at an SRP site, or whether they have a profile such that the condition is one that will be resolved, you know, just within a brief period of time. And so, like I said, this is going to be upcoming policy revision for us, and is really driven by the publication of the DOTIs that Lieutenant Colonel Stevens was talking about. The ACFT is another one that is kind of currently ongoing, and so the most recent ATP publication and guidance as it relates to ACFT implementation is also going to drive a lot of the revisions that come out of our section as it relates to the profile and whether or not the ACFT, or what conditions in particular, or not conditions, but what activities within the ACFT you know, are required for a service member to be able to perform, and then if they can't perform those activities, what happens as it relates to a medical board referral. And so those are kind of upcoming policy revisions and decisions that are going to be required here in the relatively short term. although obviously we all understand that policy revisions are not something that happen overnight, and so it's something that we've been given a lot of thought of, but it's going to take some time to actually implement for the services.
All right. Well, thank you very much, sir. Sir, what would you like to go into next?
Let's see here. I think what we were going to talk about was we talked about what's the most what has the biggest impact in terms of driving individual medical readiness. And I think Lieutenant Colonel Andreas was going to talk about that one.
Yeah. Yes, I'll cover that. So first, I just want to say this because we didn't cover this in our introductions, but you'll see on the slides in several places that it talks about total force. And so we are a total force policy Army, and we are also a total force policy division in G37 medical readiness, because Colonel DINTAMAN is an active component, Compo 1 officer. Lieutenant Colonel Stevens is a Compo 3 U.S. Army Reserve AGR officer. And I am a Compo 2 Army National Guard AGR officer. So any of our viewers out there who are Compo 2 or Compo 3 who have any concerns about equities and in the policy, you can rest assured that this is a total force division, and everybody's getting considered when we write these policies. Okay, so the question is, what is the most impactful on the building of individual soldier readiness or medical readiness? And so I would say there's two things. One, there's the soldier, and two, there's the commander. So soldiers have to take responsibility of their individual medical readiness. They need to know their IMR status, when they will go amber at 12 months for the annual requirements, and when they'll go red at 15 months. So they have 12 months of that they're captured under their PHAs and dental assessments and exams. And at 12 months, it goes amber, saying, hey, you need to do this again. It's an annual requirement. They have a 90-day window to recapture their assessments and exams. And then at that 90-day mark, at the 15-month mark, they go red. So they go on the red list, and everybody's looking to see why they haven't been reassessed to make sure that they are healthy and strong and ready for deployment. So they need to know that. They need to know what their dates are. It's kind of like their Army birthday. They need to know when they're going to celebrate going back to their provider and their dentist to get another look. They need to know their PCM, their primary care manager, and their primary care manager nurse, and using online systems to communicate with them and set up appointments. And then they also need to have familiarity with the facilities that they have access to for IMR, their clinics, their MTFs, and all that other things. The familiarity tends to help them being more comfortable with reaching out for appointments and seeking that care. So just like they're responsible for, they're individually responsible for passing their PT test and being prepared for their PT test, they need to do the same for their IMR. And then the second part is the commanders. The commanders staying focused on their soldiers' medical readiness. I just finished battalion command in May. And that was part of my responsibility, is continually looking at where my soldiers were with their medical readiness, who was going to become amber and who was going to become red, and getting them appointments and following up and ensuring that all their paperwork came back and got in the systems of record. So commanders, they need to utilize the commanders portal that we provided for them, and take the training so they're comfortable and familiar with that portal. They need to know their soldiers' IMR status and track when they need to attend PHAs and doctor's appointments and dental appointments and all that other stuff. Because commanders need to remember this one thing. And I had this as one of my mantras as a commander, is you can't deploy a vacancy. And what I mean by that is, if the soldier's not medically ready, they're not getting on that plane. They're not getting on that bus to go deploy with the rest of the unit. So therefore, that soldier gets pulled aside, and now you have a vacancy going forward. And when you go forward into a deployed environment to do a mission, it's hard to do it with a bunch of vacancies. And those vacancies can be mitigated just by paying close attention to the medical readiness. The commander soldiers can be the best trained and the best equipped soldier, even in the unit. But if they're not signed off by the medical staff as individually medically ready, then their position on the deployment roster is vacant. So those two things are to me the most impactful: is the soldier paying attention, the commander paying attention, them working as a team to make sure all the requirements for medical readiness are met. And that's on top of training, and that's on top of some other things. Because like I said, if they spend all their time out in the field training and none of their time in the clinics and MTFs becoming medical ready, then their high-speed training is all for naught.
All right. Thank you very much, sir. Go ahead, sir.
Yeah, I'm going to jump in. I totally concur with Lieutenant Colonel ANDREAS' assessment, and I appreciate his perspective as a battalion commander. That is 100% absolutely correct. A couple of points that I want to touch on is that if you are a leader of soldiers, if you are a commander or if you're an NCO leading soldiers, you have to understand medical readiness. It is not something that can be paid lip service to. And so if you're a commander, as Lieutenant Colonel ANDREAS mentioned, you have to have access to that commander's portal. And you have to be communicating with the profiling providers for your soldiers so you can make individual deployment determinations for those individuals. As I mentioned, earlier when I was talking, prevention is always going to be better than trying to mitigate the after effects of an injury or a condition that's been allowed to kind of fester. And so in many ways, that can expand and apply to just about any condition that's going to require a profile. And that system is set up to facilitate the communication between the commander and the profiling provider. And so that clear, efficient communication is essential to making sure that the commander is managing the readiness of their soldiers in cooperation with that profiling provider. The other thing I want to mention is just from a medical perspective. So we've talked about kind of the individual soldier, and we've talked about the commanders as well. But from a medical perspective, the medical provider's perspective, every encounter with a soldier should be a medical readiness visit. And so by that, I mean that, just because a service member is coming in for a one particular complaint, it doesn't mean that that provider can't take the opportunity to check on the IMR status of that service member, to check if they have a permanent profile, to see has the condition as it relates to that permanent profile, has it changed at all? Does the profile need to be modified, or is it currently valid? Those are all important questions that really should be asked at every medical every medical visit, regardless if it is a readiness visit or not. And when we can get into that mindset that every medical visit is going to actually encompass medical readiness of that service member as well, I think what we'll find is that it will relieve some of the burden on trying to tackle everything at that one PHA appointment or that one medical readiness visit for that service member on an annual basis. And it gets our medical providers also in the mindset of, what am I really here for? You are really here to actually provide a medically ready fighting force. And so even though that individual might be providing care for one particular specialty or maybe not part of the readiness clinic, if we can ingrain in our medical providers that every visit needs to be a medical readiness visit, I think that will help us to try to meet some of the goals that we've set for the Army moving forward in terms of medical readiness. So those are just the other two things that I wanted to highlight as well.
And I'll close out just saying, being proactive versus reactive. Everything will will fall into place, as what my cohorts here have touched on. Just being proactive versus reactive, and we'll get there.
Okay. And I really appreciate the sharing of the slides and the information, as well as answering the questions. From what I'm seeing from our discussion, there was a couple more slides left, but from what I'm seeing also, we have about 15 viewers right now, and we got up to about 30 viewers who enjoyed the conversation that we had today on medical readiness. Team, is there anything else that we'd like to share as far as comments or questions in closing of our discussion?
I think one of the things that's coming out here shortly is our sickle cell trait screening program. And so I think I'd love to spend a little time talking about that. It is obviously it's a more, kind of smaller effort, but it is one that we're pushing out for the whole force, and one that, most folks may be unfamiliar with. But I want to, our implementation date for that is coming up here quickly in the beginning of November. And if you're a medical provider, or even if you're in the force, we want you to be aware of this. And so sickle cell trait is a genetic condition, and it is a condition that's inherited. Those individuals who have sickle cell trait, in large cases, it's entirely a benign condition. And the Army currently screens for sickle cell trait for certain MOSs in certain schools and certain jobs. And the reason for that is because in kind of stressful situations under high exertion, those individuals can be at risk for a condition, exertional condition, that can actually lead to permanent disability, injury, or in the absolute worst cases, death. And so the Army basically looked at this and said, you know what, there are service members within our ranks who may actually have sickle cell trait and who don't know it. And we want to not only kind of mitigate the risk of this condition amongst just for individual schools or just for individual MOSs, we want to do it for the entire force. And so so we will be implementing, or the Army, I should say, will be implementing universal sickle cell trait screening starting in November, and it will occur on a rolling basis for the existing force, so we can kind of complete the screening for the entire force. And then it will also occur at the same time at IET sites for new recruits as well. Individuals who are identified who have sickle cell trait will receive specialized education. They'll receive an ID tag, a red ID tag to alert those around them to that condition. And then if there is training that's occurring, or if there's a mission occurring where there's going to be concerns about high exertion, just special attention needs to be paid to those individuals, or the medical providers just need to be aware of that individual's condition, because as I mentioned, under the right environmental conditions, those particular soldiers can have an exacerbation that can be significantly can hurt them significantly. Individuals who are identified as having sickle cell trait are not going to be limited for any duties. It is not a condition that will impact accessions, promotion, or any consideration for schools or assignments or anything like that. It is done entirely to improve the safety operating environment that we have for our service members, and to give the commanders the ability to try to reduce that risk among their ranks if they have service members who have that condition. So hopefully folks in the audience have heard about this this plan, and if not, we are happy to discuss it in further detail. But the plan is that we'll start here in November and continue then on an ongoing basis. And one other thing I was going to mention about it, but no, Oh, I know what it was. Sorry. The other aspect of this, I just wanted to make clear. The other services, the Air Force, the Navy, they already do universal screening, and so in this case, Army is going to go ahead and align themselves to the other services and go ahead and push forward with the policy of universal screening as well. And so this will ensure uniformity amongst all the services in terms of screening for this particular condition.
All right, and I believe unless anyone else has any other points to share, I think that would be, I guess, the conclusion of our live stream panel regarding medical readiness with this awesome team that I have here. I just want to say, coming from the Office of the Surgeon General, we really appreciate you taking the time today to come and just share the wealth of knowledge, giving everyone kind of like the raw numbers and the raw data, showing the importance of how important medical readiness is to our fighting force for mitigation of potential issues with deployment, and just letting us be aware of the different things that the Army is implementing right now to increase our fighting force across all MOSs. So I just want to say thank you to the entire team for coming and talking with me today.
Thank you. Thanks for having us.
All right, and everyone.
Thank you. Appreciate your time.
No problem, no problem. And we will talk a little later. Thank you, y'all.
Thank you.
And in closing, I want to say to everyone, medical readiness is an absolute necessity across our fighting force. With a stronger, more medically ready association, organization, and soldiers, we can always be at the pinpoint of making sure we can properly exert whatever necessary medical attention, whatever necessary fighting force, and whatever necessary strength that we need in our Army. And as I say in closing every time, as I say in closing every single time, Army medicine is Army strong.